It looks like people are coming through now. Welcome, welcome. Good afternoon. Please file in politely and take your virtual seat. It's great to have you join us today. We're just 1 minute ahead of schedule, so we'll let people file in just for another minute, but we will try to kick off promptly at noon because we've got a packed agenda for you today. Great, welcome everybody that's just coming in. Excited to bring you this collaboration today and looking forward to the questions that people might have. Great. And that brings us to noon. So good afternoon, everybody. Thank you so much for signing up. I think we had a record 95 people signed up for this. And so we're at 30 now. So I expect a few people will be trickling in, coming across from meetings. But I just want to introduce myself. I'm Sarah Felix. I'm the Director of Engagement and Influence here at Social Finance. I moved here at the start of the year, was previously on Neighbourhood Health at the Department of Health and Social Care. So this is a topic close to my heart. But for those of you who don't know who Social Finance are, we are a purpose-driven organisation that uses expertise in innovative finance solutions to tackle enduring social issues. And our two main areas of focus are prevention in the broadest kind of sense and scaling ideas that work, with lots of projects within that. And I'm delighted to welcome you all to this webinar, exploring the potential for social investment into mental health spaces. So we're delivering this in partnership with the brilliant Design and Mental Health Network, a UK-based charity dedicated to improving mental health outcomes through better design. You will all know, and hopefully one of the reasons why you're coming to the event today is you're aware that the spaces in which care are delivered have a profound effect on the health outcomes. And we know that there's a community and neighbourhood mental health spaces are vital, and there's a real opportunity with the neighbourhood health agenda to deliver holistic, preventative, and place-based care. But it will be no surprise to you that too often those spaces are outdated, underfunded, inflexible buildings, often a converted semi-detached home, and they're not really fit for purpose for the sort of modern, innovative care that we really want to be bringing this century. Mental health also doesn't receive that parity with physical health that it deserves, both with regard to design and investment. Historically, investment has been directed primarily towards large-scale acute type care facilities, leaving the community and place-based assets underfunded and undervalued. And so to meet that gap, we've assembled a brilliant panel for you today to explore what role social impact investing could play in funding buildings and community assets that would improve people's health and well-being through preventative, integrated physical and mental health care. So what we're going to do today is we will hear from Toby, the founder of Social Finance, about the concepts of social investment and social outcome partnerships. And then we'll move on to Katie, also from the Social Finance team, with Roz about the work that they've done together in West Hertfordshire to talk through what this actually looks like in practice and how it works in the neighbourhood health context. And that will be followed by Charlotte, Hannah and Anisha to discuss the role of the environment and design in neighbourhood and mental health and the opportunities for improving well-being by driving investment in this space. There will be lots of time for questions. We're aiming for, depending on how quickly our presenters speak, between 15 and 20 minutes of questions. Please use the Q&A channel. There's a chat thread and a Q&A thread. It would really help us if you can keep the questions in the Q&A thread. And if you see questions that interest you as well, please upvote them and we will try to answer the most popular questions when we get there. As we only have an hour for today's session, I should say that it's an introduction to the concept of social investment and beginning to explore how we could approach applying this to the mental health spaces. But it's a teaser and there'll be a QR code at the end and a link in the chat for a follow-up session. If that's something of interest to people, we'd be really happy to put something on to get into sort of further practical detail, and we will share more information about that at the end of the call. So without further ado, I'd like to welcome the brilliant Toby Eccles. Let me just get the slides up for you, Toby. They're just loading.
Thank you ever so much.
Now, over to you.
Right. Okay. If I press... Okay, you're going to... Brilliant. Thank you. I do not want to take control. Right. Hi, everybody. Very much looking forward to this. So let's just start at the beginning. What is impact investing? It's a movement that's really grown over the last 18 years of saying that investment should take into account the impact of that, and not just in the negative sense of, oh, we're no longer going to invest in fossil fuels or something similar. It's saying actually impact investing is about putting your money towards things that make a positive difference. So it is bringing an investment mindset into the world of social or environmental change. And, you know, it has grown tremendously. You can argue there are bits of it that feel a little bit like, you know, wearing a sort of Make Poverty History armband in Mayfair, but a lot of it is also very consciously making a real difference in terms of what's being invested in and growth of vital infrastructure for the environment and other areas. Okay, so in the social impact or social investing frame of this, it's really looking at the social concepts rather than the environmental side of it. And it is, you know, typically because investment focuses so much on measurability, it's also looking at positive, measurable social change alongside that. Next slide, please. So the impact investing spectrum, I think this is just, you know, I can remember early on in this, I kept getting asked questions of, you know, is it right for people to try to make money out of social issues, for example? But in a certain sense, there is very limited philanthropic capital in comparison to investment capital. And so the value of really thinking through, you know, where can money be used as efficiently as possible? And when we look at property type elements, grant money is never going to get us there. And therefore, using some kind of social investment mechanism, ranging through, and here, if you imagine philanthropy, you never get it back. So it's a minus 100% return on investment for an investor, through to where you're bringing together some grant money, some financially oriented finance and blended finance. And then you may be saying, look, we focus on the impact of what we're trying to do, but we're also trying to stay with some investment mechanisms and thinking in there. And then saying, you know what, actually you can generate a market rate return and also generate impact. And if you do so, then you can bring enormous amounts of capital to bear on those kinds of impact problems. So each of these has got different communities of specialists focusing on them and different issue areas or product areas, if you like, where they are relevant and the most valuable. I would say that most money is still, you know, one or other end of this, but we have been doing an enormous amount of work over the last 18 years on this impact first investing. Okay, now this, I think, was put in by colleagues to see whether I'd check the slides before the actual presentation. So it's a bit harsh. But we launched the first of something called a social impact bond back in September 2010, when I didn't have a beard and looked quite a lot younger. And it's really the first of an instrument that then, to our slight surprise, really spread around the world, called social outcomes contracts or payment by results mechanisms in the US and elsewhere. And there's now been, you know, well over 250, I think, of these around the world, with more than $500 million invested in different places all over the place. So let's have a little look at this, because I think it may be relevant to some things that we're looking at here. So the base challenge that this was aiming at was, you know, there are so many areas, and the first we focused on in Peterborough, where government and others will say, we know that we get poor outcomes, but it's very hard for us to put services in place if we don't think that they will work, or we're not sure they'll work. And in Peterborough, it was support for short sentence offenders to reduce their reoffending. So we offered a contract which said, look, we appreciate that problem, so you only need to pay for the difference that it makes. You don't need to pay for a service that doesn't work. And We will agree what that means. So we will design with you a set of performance measures, and we will create a contract where you only pay for the difference that's made. We will then find some of those social investors to pay for the service and support the service in the meantime. And we will then set that contract up with a series of delivery partners actually doing the work. And we will measure those outcomes together according to the mechanism that we've agreed. And in the event that that's successful, then you pay for those outcomes. And it also demonstrates that this is an area or a service area that is worth doing. Now, I think this has evolved over those 18 years considerably, and different versions have been used in different places, focused on different use cases or different functions. But the critical piece here is we have found that this has made a difference, not just in terms of whether government can try things out, but also allowing for services that can adapt to the circumstances that they're in and that are pushed towards learning things. So instead of having a 3-year contract which says, please, under no circumstances, change anything, please don't learn, instead you get a contract which says, actually, please learn, because otherwise you're not going to do as well out of this as you should be. And so it shifts the incentives around, and it actually enables frontline staff often to do what they wanted to do in the first place, which is why it's made a real difference. And my final slide, Sarah?
I think this is your final slide, Toby. I think Katie was going to do the next one.
Katie's going to do the next one. I apologise profusely.
That's all right, it's me.
But it was seamless,
a
seamless segue. Thank you.
Brilliant.
Over to you, Katie.
It was. Thank you very much. Yeah. And so one of the spaces that we've really been able to test those social outcomes contracts has been in the health space. And we've been thinking about it in terms of some of the problems, the systemic problems that are in the health service that prevent them really managing to achieve what it is that they're looking to achieve. And what you will all recognise, I'm sure, is that the current sort of vicious cycle of investment into acute services, where people are really quite often firefighting what's coming through the door in the hospital, and all the funding mechanisms are set up to deal with that firefighting and to therefore increase investment into those acute services. And what that means is you have a real lack of investment into the preventative services that would keep people out of hospital or keep people well for longer, which just leads to this cycle that you can obviously see, and I'm sure a lot of you will recognise. And what we're hoping, as you can see on the right-hand side there of the slide, is perhaps with a social outcomes contract and a new funding source, you can disrupt that cycle. And if by increasing the investment into the preventative space, you can reduce those pressures on the acute services and therefore enable some of that money to flow around the system more effectively, and really enable that shift left from spending on treatment into spending on prevention. Next slide, please, Sarah. But of course, that's challenging, because if it was easy, people would be doing it already. And obviously, I don't want to tell you all things that you know already, but it's challenging because people are busy. It's really difficult to think about things in a new way with little or no money to invest. Indeed, one of the things that you can see is a problem, working across the health sector, is that you can run pilots, but these don't get taken up into longer term contracts after an initial period of funding. And as well, doing things differently can be seen as risky. So especially where you're putting precious money behind a new idea, that's tough to do. So we've really thought about this. And next slide, Sarah, please. How can we really think about addressing those challenges that NHS and other health sector colleagues face? And what we've been doing in the last couple of years, and Ros will tell you shortly about the real example we're doing in West Hertfordshire with our Vanguard site, is the development of a Neighbourhood Transformation Fund, which brings that social outcomes contract model into a place-based approach, where you have the opportunity to think about social investment at a kind of place or regional level. So here's a diagram of how this is working, where at the heart you have a community interest company that is based in that place, which is receiving investment. And we've got a really great investor at the moment in Macmillan Cancer Support. They're a vanguard investor, really setting up this new initiative as quickly as we can get going. And Ros will tell you more about the work that they're doing. So they're putting the money in. And the community interest company is overseeing that social outcomes contract and the work associated with it. They're contracting also with delivery partners who are at the moment, first off, providing a service for people living with frailty. And that community interest company also receives the outcomes payments, which in this initial case are from the NHS. And that community interest company is therefore able to give a return back to that initial investor. Alongside this, one of the things that's really important to this programme is the Anchor programme, which is grant-based, but is looking to boost the capacity and capability of the voluntary and community sector. That's seen as really key to supporting the success of any initiative that's really looking at changing and shifting from hospital-based care into the preventative space. So really making sure we're not neglecting the work and the impact that the voluntary and community sector are achieving and supporting in the work that we're doing. So I'm going to hand over now to Ros, who is going to tell you more about what the actual work is in West Hertfordshire.
Thanks, Katie. Hi all. So I'm a development director in the South and West Hertfordshire Health and Care Partnership. And as Katie said, we're really, really fortunate to have been able to work with Social Finance and with Macmillan Cancer Support to establish a Neighbourhood Transformation Fund, which is a community interest company that we've been able to set up that has allowed us to establish this proactive anticipatory care service. It's a new model of care akin to neighbourhood health services that allows us to provide really dedicated, intensive, wraparound and highly personalised holistic care to a risk stratified cohort of our population. So what this service does is it targets our most frail individuals who are at the greatest risk of hospitalisation and provide some really, really targeted support to them. We know that for this particular cohort, that if we don't provide care in this way, they are highly likely to end up in hospital with an unplanned admission or ED attendance, which is a poor use of resources, but most importantly, it's a really, really bad experience for those individuals. And providing this proactive care is a much better patient experience for them, and it allows them to be more directly involved in the way that they plan for the outcomes that they're going to receive. Why this is so novel and such an exciting model of funding this for us is that we know that it takes time to ramp up a service like this and to achieve the outcomes that we want to achieve for the population cohort, but also for shifting resources around the system. So it allows us to step away from a from a single year funding arrangement to something that looks more like a multi-year funding arrangement, because we know that we will be achieving outcomes over a period of time. And it also gets the hospital on the hook. So if we achieve the outcomes that we're expecting this model to deliver for us, many of which we will be detecting in the hospital setting, because we expect there to be a significant reduction in A&E attendances, non-elective admissions, even elective admissions and use of outpatients for this particular cohort, then it's the hospital that is experiencing that financial impact and will be paying back through the Neighbourhood Transformation Fund for the repairable grant mechanism. Really importantly, we're phasing this model of care across our health and care partnership. We've tested it first in one of our neighbourhoods, and we'll then be rolling it out. What this also enables us to do is have a matched cohort so that we can really understand what the impact is that we're achieving, because otherwise we're trying to count something that isn't happening, because we're talking about a reduction in length of stay and a reduction in emergency admissions. We know that this will also deliver other really positive impacts for our population and for the service users, better experience. It's also going to have an impact on resource use in the community sector, in social care and primary care as well. But the match cohorts lets us really understand that we are achieving the outcomes we're expecting to, and that will trigger the repayment mechanisms. And as Katie said, we also have the anchor programme, which we see as pretty fundamental for building that grassroots capacity and capability within our voluntary community and faith-based sector, because we see the social prescribing and the non-clinical demedicalized elements of care and lifestyle support as something that is very, very fundamental to this model in achieving the quality of life and also the outcomes that the service users are expecting to experience with this service. And it's all underpinned by this community interest company, which we said at the start, it is locally held. It is a local company, and I think that's really important. It is embedded in the community that we're serving. Thank you very much, and I think we're moving on to the next slide now. So this, sorry, I don't know if it's me who's talking to this one or not, but this is, for me, based on our experience from delivering this model of care within a physical health service for our proactive care service. It feels like there's some really good natural fits that would translate this across to a mental health space where there's the clear need for investment, where it is hard to shift the financial structures and to access the loans. And I think having these really clear health outcomes, what we're trying to achieve, that take time to achieve the outcomes, and it's through a sustained model of care. This is where we've found that that this form of social investment is really, really impactful and can make a really strong case for developing a new service or a new way of delivering care. Thank you.
Brilliant. Thanks, Roz. Katie, is there anything else that you wanted to flag on the social investment part of this before I put up the QR code for the NTF?
So I think, no, absolutely, to second everything that Roz has said, particularly about the really building the role of the voluntary community and faith sector. And then in addition, I think this is one of the things about social investment, that it's often able to take some of the risk out of investing in a new service, because that risk can be taken on by the socially motivated investor. So if you need to try something different or new, you've got a supportive investor behind who is prepared to take some of those costs in ramping up and to see that over a number of years. So that, I think, is all I would say. And I think on the next slide is a QR code to give you a bit more information about the Neighbourhood Transformation Funds. This will obviously go out afterwards so that you'll be able to access this as well if you don't get a chance to take a screenshot of it now.
Brilliant. I'll leave it up while I enter the next part. That's really great. It's great to hear how the model is taking shape and to hear about something contemporary, because neighbourhood health remains at the forefront of lots of the kind of health agenda chat. I guess paying for what works, having the payer only pay for what works, capturing your learning on the way, and better patient experience and outcomes, what's not to love. We know it's not without some teething issues, so I expect some people will come in for some chats, and we've got some follow-up questions that we can ask you about more of the nuts and bolts on that. But before we open up for questions, please welcome Charlotte Burrows, the Chief Executive of the Design and Mental Health Network, Hannah Arnott, the Senior Editor of the Cities and Health Journal, and Anisha Mayer, UK Head of Healthcare at WSP, for the next section, which will focus on designing environments for mental health. So Charlotte, over to you.
It's over to Hannah first. Who's going to kick us off? Hannah, you're on mute.
Thank you. I'm going to share a little bit about translating the research in relation to restorative environments into real-world design, and looking at from a macro scale. So from the perspective of designing for community wellbeing at scale, we can think about it in two different ways. One about identifying and planning for health promoting environments, but then how that ultimately forms, designs, facilitates and maintains restorative community assets, and how we might think and frame those. So a preventative health-focused lens can guide the development of community and neighbourhood assets for mental health place-based infrastructure. And the evidence suggests that there's sort of different ways that this can be understood in terms of impact, and particularly in relation to social value. So that sort of first circle picture on the left aims to show that we've got this one aspect where the evidence shows that it has a momentary and experiential impact within the built environment at that individual level, but then also at that collective level, that long-term impact and value creation from investing sort of in the built environment, and how that ultimately has an impact on supporting mental health and physical health outcomes. So in the context of community well-being, I think what's important to reflect on is that it's psychological as well as physiological. I don't know if I accidentally, I'll just go back to this slide. So it's psychological and physiological, but it's also sort of beyond the individual, and it's really about sort of the local context of place and how that's experienced. And that's something that Citizen Health publishes in terms of, sort of urban health equity and urban health research, and we did a special issue sort of looking at this in more detail, particularly from the psychological perspective a few years ago. And that's what some of these dimensions summarise really. It's how we can think about what is health promoting, sort of the key factors and areas that are experiential but contribute to this sort of long-term impact. So one is around the quality of the infrastructure, and I'm sure this will be familiar to many people on the webinar, but some research suggests, particularly in terms of certain buildings, when there's defects, that can have a relationship with causing psychological distress. So there's sort of think about from that perspective and the quality of the infrastructure, but also the type of building. And some research shows things like sort of high-rise buildings versus low-rise buildings that can also have a negative impact on mental health. So it's also thinking about the overall design. There's also lots of evidence around the therapeutic value of space in the built environment. And again, I think this is very well evidenced and very much kind of in sort of in thinking about health promoting solutions in different ways with particular groups, but also specifically within wider environments about blue and green spaces. And I think Anisha's going to talk a little bit more about that in her slide. But it's also thinking about how these spaces can impact social connection and community well-being, and certain activities that are held in those spaces that can also influence that. Then we've got process. So think about the social processes that influence the formation of spaces and how they're perceived. So very much sort of developing healthy, safe environments rests on engaged and societal involvement and the participation. And then we've got social connection. And again, there's sort of debate and differences in how that's defined in different contexts. But there's evidence that shows that the built environment can influence things like loneliness, but also things like open outdoor areas can positively relate to health, and again related to activities experienced or perceived or within the community setting. And then finally, we've got inclusive design, and behaviour science in particular can support understanding what is needed for specific population groups, where that's in terms of risk stratified groups, but also needs such as neurodiverse communities, and whether that's sort of more sensory related. But there's research that shows that, but it's also an important part of that design process and how that's considered and tailored. So ultimately, with an understanding of these dimensions, and these just being some of them, these social processes can inform and design restorative environments, which help facilitate that social value within the community and contribute to integrated health outcomes. So we're going to ask just a few questions, so you've got an opportunity to reflect on it in your own context, and it'd be really interesting just to know how people are thinking about it sort of within their own settings. So we're going to try doing some polls, which I think
it's launched, Hannah, so attendees should be able to see it coming up now.
So first question, if anyone would like just to share their initial thoughts, is around community wellbeing. So how often are community members, or for you it might be specific service users, involved in shaping the design of neighbourhood spaces that support mental health? So no right or wrong answers here, just kind of a bit of a quick reflection on what you feel from your perspective. And people may want to think about it, and we can look at the results of these sort of after the webinar as well, if you want to have a bit more of a think. I think some people might have problem accessing the poll, but a few people can. And then maybe we could post the second question in. We're getting a few more responses, which is great.
I think people should be able to be moving through the questions themselves, so people might be, the responses will just trickle through as people answer them.
Brilliant. So in that case, I'm just going to summarise the other questions there if you're able to access that in the full polls. But the second question is just looking at how might be utilising community assets that you recognise that you have to support mental health now, and whether you feel that more can be done there. And then what might be being overlooked, and how could that better support neighbourhood mental health? Be really interesting to know how you sort of consider that, whether it's sort of the green and blue spaces, whether it's specific buildings, and then also in terms of the type of value that might be overlooked. And I'm going to stop there and pass on to Anisha.
Thank you, Hannah. So it's very clear that we don't just have physical health, we also have mental health. And so for those of you who know about the neighbourhood health centres, we very much welcome the accelerated rollout of those. But what we want to emphasise is that it's not just about the design of those centres, but indeed the environments around them, that we have to consider that's the key impact on people's mental health. So here we've got neighbourhoods of prevention, and the role I see is very much about prevention. So prevention is not only for severe mental illness, health illness, so that it escalates to the point where patients need to be treated into an acute setting, but prevention is also about the decline in mental well-being that can affect us all. And that really is, as I say, centred on the design of the centres and the environments around them. So for example, according to the NIHR, the impact of accessing blue and green spaces alone can reduce anxiety and depression by up to 20%. So in other words, an increase of 10% in access is linked to a 7% risk reduction. And so we could be forgiven for thinking that we have to really tackle mental health in our later years, but actually moving the dial is more formulated in our earliest years of childhood, actually in the first 1,000 days. And then from the ages of 2 to 5, access to green spaces actually reduces the level of emotional and behavioural problems. So in terms of a nature neighbourhood, I think that's what we like to think about, even if it is in an urban environment. And I think it centres very much on this core 20+5. So we're not really trying to target those populations that go on the park run every Saturday. It's more about those populations that have key comorbidities. So we know they are around maternity, severe mental illness, chronic respiratory disease, early cancer diagnosis and hypertension, often very much interlinked. You can see on the second image from the left-hand side of this slide what looks like a tube map, but actually it's actually from Pontevedra, so in Spain. What they've done is taken cars out of their city, and I appreciate for our cities it might not be as simple, but parts of our cities could well benefit from this. And instead of it being a tube map, it's actually a walking map, so you can go from A to B and be very clear about how you do that. And what we'd like to do, so with my other hat on and the New London Architecture Healthcare Expert Panel, we're looking at not just distances from A to B, whether that be walking, cycling, or some other mode of transport which isn't involving cars. It's also thinking about what happens on those routes, so that we curate some activities that actually do encourage those populations that sit within the 20% most deprived populations of this country. And what they've also done in that particular city is created a design of, a human scale in terms of lowering lighting, creating safety, and really importantly, encouraging people out and understanding in that map where those amenities are. So for people who suffer from certain comorbidities, they may need access to public conveniences, they may need access to being able to sit rather than just walk the entire way, for example. And then we mustn't forget that very often in health, it's quite difficult against the backdrop of economic infrastructure to always prove the business case. And we really need to think about how we measure outcomes. So whether that be, and that's Healthy Cities Generator, I don't know if people have heard about that, is quite an effective tool. So they measure against stress, anxiety, depression, cognitive function, emotional state, attention deficit, mental well-being, perceived safety, quality of life, and happiness. And then moving on, we've seen in COVID the question around 15-minute neighbourhoods, which tend to be quite controversial, but nevertheless the concept of having all your amenities in 15 minutes of your particular place of where you reside is something that can be considered. And then thinking about policy and how we craft it according to what infrastructure we have consented. So if you think about something like the Future Generations Act in Wales, it very clearly has defined 7 key areas that all have to be adhered to and demonstrated in any application. So that's around how it contributes to prosperity, resilience, health, equality, cohesion, as well as the Welsh language in that instance, and global responsibility. And if you look to New Zealand, they take it even further. So they're not just thinking about the next generation, they're thinking about the 7th generation, so 175 years hence, and really looking at planetary boundaries, circular and regenerative economies. And we can also see here that little Ella, who's second from the right, she was unfortunately the first and I hope very last air pollution related death in Westminster. And of course in London now we have the ULEZ, which is the ultra low emission zone, and there's always more that we can do to contribute to that sort of urban lung of the blue and green spaces as well. Really, really important is being able to co-create, and we think about accessibility and how we actually access these spaces. Yes, the neighbourhood health centres, but also the environments around it. NCAT has been famed for being able to do that in shaping the future of accessible transport. And it isn't just about transport. If we move across to the far left of this, that's actually Singapore. It's something called Kampung Admiralty. And we probably looked at other countries to think, well, intergenerational living is sort of the panacea. It helps populations. And it's not just as simple as that. Research has shown that if you do live together, it's not always the solution. So you could have grandparents, parents and children. Now children will go to school, parents will end up going to work, and the grandparents inevitably sit at home watching TV. So what's been essential in that situation is being able to create spaces where all the generations come together in the not too far from actually where they reside, and that's what moves the dial on prevention. And so what we advocate is a systems thinking approach, which makes it a sort of scalable, adaptable system, but really importantly, not a copy and paste. So we do need to think about, as I said earlier, the co-creation with the populations that are going to be benefiting from these spaces and centres. So thank you. We'll welcome some questions after this.
Brilliant. Thanks, Anisha. And Charlotte, over to you for this next slide. Thank you.
Thanks. So I'll bring it back down to maybe the more micro level, thinking about design and place. And clearly the image before us is not a building that we would want shaping our health outcomes, though how confident are we that the spaces and places that we're designing, redesigning, building, refurbing are actually enabling better health. And while buildings and so these spaces might not treat people, they play a critical role in how you feel, and those who work in the community know how you engage with care, how you get to those places, how you connect with your community. It doesn't happen in a vacuum, and it happens in an environment, and those environments are not neutral. And too often, particularly as Sarah highlighted in the beginning, with regards to mental health, in particular, those community spaces, those spaces of care are underfunded, outdated and inflexible. And when design is applied, it's often seen as a cosmetic rather than something around how the building is part of that care. And that has a cost. These spaces can trigger trauma. Poor flow can undermine access and can create hidden costs, inefficiencies and disengagement. But really, on a kind of practical note, there is an opportunity. We're thinking both differently about investment and about the approach to think about what does good design look like, what can make a tangible and positive difference to patient wellbeing, to improve those who are providing care. Design qualities that have positive impacts, such as access to nature, it's been highlighted by Anisha and Hannah, fresh air, privacy and control, clear wayfinding and sense of place. So I want to kind of highlight that this is about, practical opportunities as well as thinking at a larger scale. Evidence shows that relatively small, well-considered changes can have meaningful impact, particularly from an inequity point of view. So thinking about those who are least likely to be able to access services and the impact it has, which disproportionately impacts those people. So access to natural light, reducing glare, supporting circadian rhythms can improve well-being. Sound, again, rather than having really noisy environments, thinking about reducing noise, simple acoustics, changes how a space feels. There is a huge amount of evidence written about colour and material and how to reduce a clinical feel and create more calm, more familiar environment. And wayfinding, finding your way can create massive stress, and people walking to neighbourhood health centres are going to be coming in, they may have dementia, they may be neurodiverse, they may be struggling by just looking after a family member. We can ease that burden and make finding our way to care more conducive. And the wider kind of sensory environment, so everything from smell and ventilation. This isn't just about kind of new builds. This is also about thinking about refurbishing the spaces that you've got, using the legacy of that environment and turning that into something that's better for communities. There's, like I said, a really important equity dimension here, because often those poor environments are found in areas of greatest need, and either we're redesigning and reinforcing those inequalities, or we're making a choice to try and design out those inequalities. So I think, sort of to conclude, design with empathy, start with the communities and with lived experience. There's practical ways to do that, and there's an opportunity to think both differently about the investment and the way in which we look at investment solutions and opportunities, and the way in which we apply that to improve better health outcomes. And I'll pause there we can move on to questions.
Thanks, Charlotte. Thanks. Whilst you have the virtual mic, as it were, the floor, I will start with a question for you. And there's a question in the chat which I'll pull across next. But from a design and mental health perspective, a lot of what you talked about, I feel like everybody would naturally agree with. That sounds like a good use of space. They sound like things that would help create more environments that are more conducive to mental health. Good mental health. What sort of transformation in mental health spaces would you like to see over the next 5 years?
Wow, that's a big question. Well, I think the opportunity starts with listening to people's lived experience to co-design, and communities to co-design those spaces. I think there's great opportunity in the community, but there's also a risk that we recreate clinical environments in the community rather than approach it in a way that is conducive to wider kind of supporting wider mental health. I think we still treat design as a cosmetic rather than as part of the opportunity around solutions for care. And I think in the community, again, there's that opportunity to think about, well, what does better mental health spaces mean at a macro level? Like how, what are the transport systems? How are people arriving? What are the green spaces? What are the blue spaces? What are the access? And at the micro level, right through to the design choices, are we making the places in which people receive care accessible, inclusive, or are we creating boundaries so that you arrive feeling undignified, the environment is further traumatic, and the space feels cold, clinical, and not conducive to improving your care or those that are trying to support you, because there's a number of people that work in those buildings, and it's important also that we take care of staff and those working in mental health. So that's a kind of a starter, but yeah, that's a conversation and a webinar in itself. But
no, that's great. That's great. Food for thought. And just to pick up the question from Kerry Moore, who highlights that there may be cultural differences between the VCFSE sector and the way it operates and the slightly more bureaucratic, red tape laden NHS. Katie, coming to you for a question about, do you think social outcomes contracts, social outcome partnerships can help the VCFSE sector be a sort of more viable partner? And I think perhaps the subtext there relates to long-term, more secure funding for VCFSE.
Yes, absolutely. Yes. So I absolutely think that it can. And in fact, the Neighbourhood Transformation Funds were designed with this in mind, to really be able to support the voluntary community sector in being able to demonstrate the outcomes that they are achieving, and just for the statutory sector to really be able to see that impact as well. So I think one of those ways is being able to bring them into the room and to be able to demonstrate, really think very carefully about how those outcomes that are being achieved by the voluntary and community sector can be recognised by the statutory sector, and through the mechanism of a social outcomes contract, where the outcomes repayments are a kind of a currency, if you like, that is recognised by the statutory sector as a way of saying, yes, we see what you're achieving, and ultimately you are demonstrating that business case, as Toby was talking about in his bit of the presentation. You're really starting to demonstrate that business case for a successful service intervention as you go through a social outcomes contract. And absolutely, it's part and parcel of the work that we've been doing in West Hertfordshire. As Ros, I would be able to confirm, I'm sure, that we're really bringing the voluntary community sector right absolutely up front into this particular programme of work, to make sure what they are is doing to support the services that are being set up or recognised and supported, both financially and in setup terms, and also in terms of sustainable funding as well for the future. So yes, I would say that it's an important part of the work that a social outcomes contract could do.
Brilliant. That's very helpful. And of course, neighbourhood health, very contemporary at the minute. You could say one of the flagship policies in the 10-year health plan, and we've recently seen the guidance come out on health centres. So Ros, some NHS decision makers, perhaps the sceptics among them, might think that social outcomes contracts are too complex, too slow to set up. What would you say to those naysayers?
Well, I'd like to think that we've done a bit of the hard work already and done a lot of thinking about this, which we're very happy to share with others. I mean, I will be honest, it has been a journey and it has taken time to get it right. And I think there is something around doing the research and getting the evidence to agree the outcomes and be really clear what the outcomes you're measuring. And that is an important part of the process. It does take time. In terms of it being costly to set up, I think I would really challenge that, because what this does is it puts in that upfront investment to enable us to actually use resources a lot more sensibly. And we think that it'll create quite a lot of cost avoidance and potentially cash releasing savings in the acute sector in the future, that we will be able to pay back the repayable grant, but also reinvest as well, because we're not having so many attendances in hospital. We're going to really reduce the global acute spend, but we're also going to see that impact in primary care and in community settings about releasing capacity to do things better and differently. So it should create a fairly virtuous cycle. I think maybe you need to be brave to asking Acute Trust to be on the hook for paying back that repayable grant, but we're very grateful that we have a fairly enlightened Acute Trust that really understands the benefit of this and wants to work in partnership. And I think that's the trick, isn't it? It's about bringing lots of parties together to think a bit differently, which does take time to invest in those relationships. I will certainly give you that, but we think it's absolutely worth that time. But Katie, I know you've worked with others, so maybe you know some of the blockers and how to overcome them as well.
Yeah, I mean, absolutely support everything you've said. And I think one of the things that we would, when developing a social outcomes contract from the beginning, where you're working with people who may initially be bringing on board some of their maybe more skeptical exec teams, what is it that you need to do to be able to convince them that this is the right thing? And I think there's something about everybody being very aligned behind the outcomes that we want to see, so that we're all looking to make sure that that's a real priority for the key decision makers who are going to be really getting behind that social outcomes contract on a number of different elements. And I think as well, having a service intervention that is structured, that you can structure as a social outcomes contract as well. I think being really clear on the kind of intervention that works well for a social outcomes contract. And I think finally, I'll just add, I think, getting something that you can see above the level of noise. You've got to get a particular size intervention really to suit a social outcomes contract. This is not about saying this is we've moved totally away from grant giving. There's always a place from grants. In Toby's slides earlier, you've got that spectrum of social investment. Non-repayable grants have a role, but then, when you get to a certain stage, considering a social outcomes contract as a real way to drive that sustainable change over multiple years would be, one of the things to think through.
That's great. I think we've covered all the questions that have come through on the chat, but if anybody wants to put their hand up or introduce themselves and raise either their aspirations or what they'd like to see in a future session, I'll give people a minute to do this while I just flag that there's a QR code on the screen. As I said, today was a sort of introductory session. It's a bit of what is social impact, what is a social outcomes contract, how might that work in neighbourhood health, right through to how do we design spaces for mental health. So naturally it was a little bit of a whistle stop tour, but we'd be very open to running more detailed sessions if this is something that people are interested in taking forward, and we would curate that around the sort of topics of interest. It's fine. I can see a few messages coming through about people needing to drop off, and good to hear about what they're doing at Maudsley. Absolutely. So I won't hold you all hostage to the 1 hour webinar. I'll let people wrap up, but I'd just love to say once again a brilliant thank you to our panelists, for everyone joining today, for your attention and the questions. If you've got any additional questions, Michelle has kindly put details in the chat. There's also a little follow-up, so you can provide areas that you think you might be interested in, and we can get back to you. Thanks very much for joining us, and I hope you enjoy the rest of your day. Good to see you all. Take care.
So